Good afternoon. I'm Giovanna Liuzzo from Rome, and with Professor Massimo Volpe, I will co-chair this dialogue on the long-term consequences of COVID-19 on behalf of the weekly Journal Scan section of the European Heart Journal. We have the honor to have with us Dr. Ziyad Al-Aly as guest and Dr. Luis Alberto Garcia Rodriguez as discussant. The topic we have selected, we think is highly relevant, as we should be prepared to deal with an unpredictable wave of cardiovascular diseases and other conditions related to COVID-19 over the next year. And this may have long-lasting consequences for patients and also will represent a growing burden for the healthcare systems. It's my great honor to introduce our guest, Dr. Ziyad Al-Aly. He directs the Clinical Epidemiology Center and is the Chief of Research and Development Service at the VUA in St. Louis healthcare system. He's a clinical epidemiologist at Washington University in St. Louis. He has several research interests, including pharmacoepidemiology, environmental epidemiology, global health, and most recently, short and long-term effects of COVID-19 on health outcomes. Among all the other things, he led work which provided the first systematic characterization of the post-acute sequelae of SARS-CoV-2 infections, and subsequently the characterization of the increased risk of cardiovascular disease, but not only, also neurological disorders, diabetes, kidney disease, gastrointestinal disorders following the infection. His lab was the first to produce evidence characterizing the effects of vaccines on long COVID, the health consequences of repeated infections, and the effect of antivirals on the short and long-term outcomes of SARS-CoV-2 infection. Not only, he co-chaired several committees in US, and also he serves as US government interagency long COVID coordination council, and was the advisor of several agencies, also global, like the WHO. So I think that we have a major expert on the topic we have selected. And it's really my pleasure to give him the possibility to say to us what is his point of view about this major problem.
Well, thank you, Giovanna, for this really warm introduction, and delighted to be with you, with the European Heart Journal, and your audience here today. So when I think about long COVID, we sort of think about it as the all the potentially the post-acute and long-term consequences of SARS-CoV-2 infection. And I know it's sort of a hardwired almost in the public consciousness that long COVID may be only brain fog and fatigue, but we do think that it sort of encompasses so many organ systems, actually, including the heart. It's very, very clearly from the early days of the pandemic, people started coming back to the hospitals and clinics with cardiovascular manifestations, and we decided not very early in the first year of the pandemic to sort of think about this more deeply and study it systematically. And then time and again in our evaluation of the the post-acute and long-term consequences of SARS-CoV-2 infection, there was always cardiovascular manifestations, and those sort of what's really also peculiar about it, there was not really specific. It was not really ischemic heart disease or just arrhythmias or heart failure. It was really almost all of the above. Literally a broad array of cardiovascular consequences after SARS-CoV-2 infection. What we've also seen is that while the risk is much higher in people who are hospitalized and people who needed ICU care, the risk was evident even in the population that had very mild disease. And why this is really important, Giovanna, it's really important because that really represents the lion's share of people with SARS-CoV-2 in the world. Most people with SARS-CoV-2 in the world have actually mild disease, some of them even asymptomatic disease, that sometimes is discovered incidentally. So even in that population, there is sort of an increased risk of cardiovascular complications. And in addition to sort of the cardiovascular space, I think what is also really interesting about SARS-CoV-2 is that there is really increased risk of some of the proximal risk factors for cardiovascular disease, including increased risk of diabetes, increased risk of hyperlipidemia, and several other disorders. So you can see sort of almost like this is really the perfect storm, for potentially leading to some contribution to increased burden of cardiovascular disease at the population level. The good news is an introductory remarks is that throughout the pandemic, the virus has evolved, and arguably the subvariants of Omicron now are milder than the ancestral strain and Delta. And we also have, in addition to some population level immunity, we have a lot of people who have been vaccinated in the world, in the US, in Europe, and around the globe. And we also have the availability of antivirals, which are also available to some extent in various countries around the world. And those certainly ameliorate or reduce the risk of post-acute or long-term complications of SARS-CoV-2. So that's sort of the general, when I think about sort of the long-term complications, and really delighted to have the Q&A and discussion with your group and your team and the audience.
Perfect. I think that Professor Massimo Volpe would like to ask something. And I see also Professor Crea that just joined us. Maybe he would like to say something too. Massimo, up to you.
Well, after Filippo.
After Filippo. Filippo, please unmute you and say something.
Yes, well, first thing, thank you, Ziyad, for dedicating your time to our dialogue. And of course, this is a very relevant topic. We also published a paper in the European Heart Journal from Stefan Blankenberg. This was an assessment of patients with mild to moderate COVID a few months after the infection. It was a multi-organ study showing frequent subclinical multi-organ alterations. So the topic is extremely relevant. Now, a first question I'd like to ask you is, first, what are the mechanisms? Again, in the European Heart Journal, we published a very nice paper from Peter Libby, and the title, and Tom Leusher, the title was, well, eventually an endothelial disease. Endothelial activation seems to play a role in this setting. So two questions. First, what is you think is the main mechanism leading to this multi-organ disease? And second, what is the impact of vaccination on this long-term disease?
This is really brilliant. Thank you for that. So when I think about long COVID, and because it's sort of really varied, and even if you only want to sort of think about the post-acute and long-term cardiovascular manifestations of SARS-CoV-2 or COVID-19, it's really not one thing. It's a broad array of manifestations. So it's really unlikely, at least, that there's one mechanism that explains all of this. Or multiple hypotheses have been proposed, and a lot of people, a lot of labs in the US and in Europe and throughout the world have been working on those. One is the idea of viral persistence, and it does not have to be the full virus. It can be RNA fragments or small fragments of the virus that persist in quote unquote immune privileged sites, which may then lead to some level of low-grade inflammation and ultimately impacting organ systems, including ultimately impacting endothelial health and subsequently sort of the downstream ramifications of that. And that hypothesis is really is very, very interesting, because it sort of relates to SARS-CoV-2 itself potentially persisting in some individuals. And there has been some work now to suggest that antiviral use in the early phase of SARS-CoV-2 may actually reduce the risk of the long-term consequences of SARS-CoV-2 infection, including those cardiovascular complications. This is certainly not a proof of this hypothesis, but it sort of elevates its likelihood of at least partially being true in some individuals. It's not gonna unlikely to explain everything in everyone. And then hypothesis number 2 relates to immune dysregulation, and that in some people, they can either get a hyperactivated immune response, or conversely, a dysfunctional immune response as a result of the infection that then may cascade down to yield or result in organ damage. There are some proponents of the hypothesis number 3 of the microbiome dysbiosis. Not a whole lot of proponents, but some proponents argue that viral infection actually disturbs the microbiome, and there is really an intimate link between the microbiome and human health and disease, actually including endothelial function and a variety of other different mechanisms in the human body. And then the infection with SARS-CoV-2 may disturb the microbiome in a way that then may yield disease. It's very as a scientist, it's really very hard for me to sort of tell you like which one is likely to. And there are other hypotheses as well. I mean, we can pretty much spend the whole hour sort of thinking and talking about hypotheses, but those are the 3 prominent ones that a lot of people are working on. The element 2 of your question is what's sort of the role of vaccination, or do vaccines reduce the risk of long-term consequences of SARS-CoV-2 infection? And the answer is yes. So there have been a lot of studies on this, including some by our group here, and some studies from Israel, some studies from elsewhere in the US and the UK. And universally in all of those studies, vaccines do reduce the risk of long-term complications, post-acute and long-term complications, including cardiovascular disorders. The risk reduction is modest. In a lot of the studies sort of varies between 15% to maximum of 50%. Most of the studies around 30%. So there is clearly, the effectiveness of vaccine in abrogating acute disease or abrogating the adverse consequence of acute disease is very high, but then the effectiveness sort of wanes with time, so that their effectiveness against post-acute and long-term complications is generally about 30%. The good news is that it's nothing. It's not at all, like it's not zero. But reliance on vaccines alone to mitigate the risk of long-term consequences is unlikely to really make a huge dent in the burden of disease. And number 3, there are I mean, as I alluded to in thinking about hypotheses, there is now sort of a pipeline of work thinking very deeply and reporting on the role of antivirals. Again, sort of that relates to the viral persistence hypothesis, role of antivirals in potentially reducing the risk of long COVID. There was work from our group here suggesting that Paxlovid reduces the risk of long COVID. And we published a paper in BMJ about 3 days ago, also suggesting that molnupiravir, despite all its adverse event profile, and the idea that it's also mutagenic, so it's definitely not our preferred choice, but molnupiravir, the second line agent after Paxlovid here in the US, which remains under FDA EUA, emergency use authorization, also reduces the risk of long COVID. So those are briefly sort of my thoughts on your points that they were raised.
Perfect. Now,
can I? Sorry, I mean, I don't want to take advantage of my position as editor-in-chief.
you are doing
I have really one question, follow-up question.
Yes.
If we think, and then I will shut up after the second question. The second or third or fourth question is, well, we also learning from influenza vaccination. I think that in that direction also we have very important messages showing that influenza vaccination reduces cardiovascular risk. And again, mechanism there can be complex, but at the end of the day, the evidence now coming also from trials is really quite convincing as far as I can judge. So the question is, putting together COVID, which has been an extreme situation, influenza, which is sort of average influenza situation, severity, putting them together, all this information, what is the big picture you have in your mind?
So I think sort of, I mean, this is really a brilliant question. So drawing on the analogy of not only vaccines, but also the other, viral agent influenza. So the idea that SARS-CoV-2 leads to post-acute and long-term manifestation is really shouldn't be novel to anyone, because that, as you pointed out, actually exists with the flu. There is a post-flu syndrome, and there is post-polio, there is post-Ebola syndrome. Now we know EBV, or Epstein-Barr virus, leads to multiple sclerosis years down the road. So viruses produce or lead to long-term manifestations, and that treating the virus in the acute phase, as we discussed with antivirals, or potentially reducing the severity of illness, via vaccines, as sort of the COVID vaccine does, and sort of reducing the risk of hospitalization and death in the acute phase, maybe pathways to ultimately also reducing the risk of long-term complications. And I think that's really, again, we could sort of think on multiple different ways about the potential mechanisms, but I think one of the universal threads throughout almost all the literature out there on SARS-CoV-2 and long COVID or long-term complications is that the risk increases with the severity of the acute infection. And that's almost like there's a lot of noise in the long COVID literature, but there's one universal thread that you can thread throughout all of the papers, nearly universal, from US, Israel, UK, Germany, everywhere, that universal thread, one consistent finding is that the risk is evident in people who are non-hospitalized, higher in people who are hospitalized, and highest in people who needed ICU care, and in an acute phase. So it stands to reason that mechanisms actually, so we were not surprised that vaccines really work, stands to reason that mechanism that reduces or abrogate or, to some extent modulate, that the severity of the acute infections, in which case, COVID-19 vaccines do, might also reduce the risk of long-term complications. And you drew on that the beautiful analogy of the flu. So, we're definitely huge supporters of vaccines. So we're on the same page. Vaccines work in COVID and also in the flu, not only in reducing the severity of acute illness, but potentially also protecting from long-term complications. I think the other side of this is that, the vaccines are not everything, and they're not 100%. So even vaccinated individuals still end up, some vaccinated individuals still end up with long-term complications.
Okay, now I will change a little bit the schedule. Sorry, Massimo. I would like Carlo to introduce Luis Alberto Garcia Rodriguez, and then you make your question to Luis or to Ziyad, because Filippo said a lot of questions, asked a lot of questions are very crucial. So change a little bit the schedule. Carlo.
Okay, very briefly, Luis Alberto Garcia Rodriguez is a world-famous pharmacoepidemiologist. He is the director of the Spanish Center for Pharmacoepidemiology. Luis has contributed enormously to our knowledge about the gastrointestinal effects of non-steroidal anti-inflammatory drugs from the very beginning, and then later he has contributed to characterizing some of the cardiovascular untoward effects of the same class of drugs. He has also spent quite a number of years investigating the anti-cancer effects of aspirin. And so, Luis, it's a pleasure having you here and contributing to this discussion.
Okay. Just a little, add to what you said. He now has a big connection with several other institutions having a huge databases based on healthcare systems. So like databases that take care of 5 million, 6 million people. So I think that he really can tell us about the effect of the long COVID pandemic on our health system. Massimo, your question.
Well, first of all, thank you very much, Ziyad, for being with us. I was very pleased to read and comment your papers, and we have a very similar experience also in our country. my question is related to the storm, the long-standing storm on the healthcare systems in the world, and that produced very difficult times for prevention, but also for treatment of cardiovascular disease. And it is impressive to see that all cardiovascular diseases are increased, and especially like beyond coronary care, coronary disease, stroke, heart failure, atrial fibrillation, whatever. So what do you think is the influence of the lousy healthcare provisions to patients, and the consequences on the increase on the long COVID, the so-called long COVID cardiovascular complications?
Thank you again for this. So we worry about this quite a lot. So it's very, very clear from the data that SARS-CoV-2 can lead to cardiovascular manifestations and also other manifestations. It's very, very clear also that the magnitude of effect is not small, especially when it's multiplied by the huge number of people who had SARS-CoV-2 in the US and in Europe and around the globe, right? So even sort of small percentage increase in absolute risk can translate into millions of additional cases of cardiovascular disease in the US and in Europe. And I think the challenging situation about it is that also as a result of the pandemic, instead of our healthcare systems becoming even more resilient and stronger, we've seen because of a variety of factors, sort of almost like a decay in some of the infrastructure. There is a lot of mistrust, a lot of sort of people sort of burn out among physician workforce, a lot of healthcare systems that are strained to the degree that influence their ability to provide care, et cetera, et cetera. So these two drivers combined, they're likely to sort of and I hope this assessment is inaccurate. I do hope this assessment is inaccurate, but I think we have to be thinking about it and worried about it and trying to figure out like how to optimize what we have to deal with the potential surge in demand. And we're already seeing, at least in the VA system here and in some of the health systems in the United States, we're sort of seeing that surge in demand as a result of the potentially the long-term complications of SARS-CoV-2. We worry that the healthcare system is not necessarily equipped due to the factors that I have just outlined to really deal with these problems. It's the extreme of this, we see it in the long COVID clinics. We see the sort of the very, very, very long wait lines in the long COVID clinics in the United States. Some of the wait lines are up to a year, and people, eventually sort of quit, seeking care because they cannot get to a clinic a long COVID clinic in the United States. So that's really something that has to be solved. There are, some ideas in the United States that sort of people are working on. The idea that specialty care, people with, cardiologists and long COVID specialists are unlikely to be able to meet the demand, and then that empowering the primary care providers with at least the knowledge and some of the tools to be able to deal with most of these cases, because not all these cases will need really hyper specialized care, might also ease the access problem. But certainly, at least here in the US, there's clearly an access problem in long-term complications of SARS-CoV-2.
Okay.
Can I just ask Luis what he thinks about this noise related to the problems with the healthcare providers to people in these 3 years?
Yes, thank you everybody. Thank you, to give me a chance to comment. Well, it is definitely a limitation, this noise, which is very hard to quantify, because of the change in the healthcare provision. Although it's true that it applies to the whole system, but it's also true that it well could be that healthcare monitoring, healthcare surveillance was somehow stronger or more falsely implemented in patients surviving a COVID infection than in patients not surviving. No, this is just something that we have to accept. It's very hard or pretty much close to impossible to quantify the magnitude of that, if any, kind of noise, and only an experimental trial would solve that. No, which is of course just not feasible. So that's one of the things that is present there. And might slightly affect the comparison, no, between the two groups. So usually that's what we call in epidemiology, a confounding by a kind of lack of comparability, no. And here is not so much the comparability of the individuals, but more the comparability of their health attitude first, which also is another point that you didn't mention. But most likely, people who are risk averse are less likely to get many things, among others, infection, and among others, COVID infection. And people who are more risk-taking are more likely to die in an accident, and also maybe to get COVID. How this risk profile, which is the background of this patient, affect the results, for me, it's impossible, of course, to quantify, but it's something that is there. And once again, that cannot be really directly measured nor addressed, in an observational setting. Saying that, I mean, the impact of all these of these two traits I just mentioned is likely not at all to cancel the association, but might slightly reduce the estimates because they most of them play in favor of finding an association among COVID people. No, these two factors I mentioned. So the greater kind of monitoring of patients with COVID, and the less likelihood of risk-taking behavior. No, that most likely people who don't have COVID are more risk averse. No, likely. I don't know how much, but to some extent. Having said that, I mean, I want to just commend the paper because I think amidst this COVID surplus of papers we've had, unfortunately, in epidemiology, has quite drastically reduced the validity of many studies published in the literature, which papers would have never been published, 3-4 years ago, because they wouldn't have met the quality. But that's not the case of the paper we're discussing today. I think the paper was very nicely done with a rather well-validated database. I won't get into the validation of the outcomes, no, because many other studies, maybe not the one directly here, have validated these endpoints. So also the analysis, I mean, by doing adjustment by the risk profile in the year prior with high dimension and with pre-selected characteristic. All this is very nicely done. So hardly anything to say there to these methods. It's more to the context, no, and to the comparability. That's really my question. No? How comparable these people are, despite all the adjustments that were very nicely done. No, and there is still some possibility for that. Anyway, the good news of this paper for me, because I'm always a positive person, is not that COVID increased the risk of cardiovascular disorder, which it looks like it well could be in people hospitalized. The good news is that 85% of the cohort, which is non-hospitalized, if you look at the risk estimates, they barely 1.1, 1.15. And of course, this increasing relative risk in epidemiology, we really take it with a big skepticism, no? And not despite accepting that there might be a small increase. But the good news is that the vast majority of people who have had COVID, which in this study was 85%, have hardly any excess risk of these cardiovascular diseases, if I understand correctly the results. So for the time being, I'm going to leave it here, and thank you.
Okay, now before to leave the stage to Carlo, I would like to say that there are questions from the audience, and I would like to tell the audience, please ask questions, even in chat. Starting with the first question is from Geoff Hackett, and is telling us that a JAMA paper last week showed that the diabetes risk is nearly 3-fold higher in men and barely significant in women. Does this not suggest an association with the acute hypogonadism in acute COVID shown in many studies, giving the established association of hypogonadism and type 2 diabetes? What do you think?
This is very, very interesting. So, I saw this JAMA paper, and there's actually quite, I mean, JAMA Network Open paper, and there was a sort of now a body of evidence, sort of pointing to an increased risk of diabetes after SARS-CoV-2, and almost all the studies, the risk is slightly higher in males than females. So it's not non-existent in women or females, but it's sort of slightly higher in males than females. So there is a sex differences and sort of biologic responses to viral infections may be one thing. It's possible that the mechanism that the person who asked the question is proposing may be at play. It's unlikely to explain. It's unlikely to alone sort of explain these differences in the risk profile between men and women. But I'd like to emphasize that beyond this JAMA Network Open paper, there is now almost like 20 studies from a variety of systems throughout the world, showing consistently increased risk of diabetes, and that was actually true in men and women. But although that, I definitely agree that the signal in women tended to be slightly weaker, or the point estimate slightly smaller on average in all these studies.
Perfect. Then I see a question from Enrique Sanchez. I'm asking to Dr. Sanchez if he'd like to ask the question in person, or if I should read the question that is in the chat. What do you think?
I'm sorry, are you asking me?
Yes, if you like to ask in person the question that you have posted in the chat.
No, not to you, Ziyad.
Okay.
She's reading a question
Eric
from
Sanchez.
Joanna. Why don't you read it?
Okay. Role of chronic macrovascular inflammation and possible pharmacological approaches. This is the question. The role of chronic macrovascular inflammation and possible pharmacological approaches. It comes from Enrique Sanchez.
I mean, this is really a wonderful question. So as Filippo indicated, so the idea that there's endothelial dysfunction, potentially microvascular disease, and people with long COVID is there. I mean, it's one of the hypotheses that people are working on. There's also like some proponents of the microclot hypothesis. I mean, we sort of can go down the rabbit hole of a lot of hypotheses that might explain, the long-term complications of SARS-CoV-2. But it's is it change? So
sorry, we have somebody sharing the screen. We're trying to.
Yes.
We're going to stop that.
Okay, perfect. Thank
Apologies
you.
for that.
No problem. So again, sort of there are yesterday was actually the FDA, the Food and Drug Administration here in the US, hosted a public meeting to sort of pick the brain of people about the long list of potential therapeutics that can potentially ameliorate outcomes in long COVID, and there's a lot, including a lot of the medication that we generally use traditionally for hyperlipidemia, for anticoagulation, for antiplatelets, antivirals, anti-inflammatories. So there are potential ideas there. There's a lot of ideas. What's in my world, what's really not happening fast enough is really trials. Well, what we really need trials, to really help us understand what works in long COVID and what doesn't work in long COVID. And so far, there are very, 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 very few trials in this space. And in my thinking, this is really definitely not enough.
Okay. Then we have several other questions. Maybe Carlo would like to ask something, and then we go ahead with the questions from the audience.
Ziyad, I have a couple of questions. One is related to what you said earlier about other viruses also causing long-term consequences. How different is this virus vis-a-vis, for example, other respiratory viruses? Is it my impression, or is it confirmed by data, that the consequences are more widespread? And do you think this is due to the entry of the virus in a wider array of cell types than other respiratory viruses?
But this is really brilliant. Thank you for that. So the idea of a post-viral illness isn't really necessarily new. And we, even if you go back to the literature dating back to the early days of the 20th century after the Spanish flu pandemic, there were reports of people with new onset Parkinson's disease and ailments like fatigue and brain fog and all of that. So the idea that viruses can lead to long-term consequences isn't really new. I think that the medical community and the funding agency have underinvested for nearly 100 years, underinvested in understanding it. So we got caught. Now we have to sort of like almost start from scratch. But there are two key differences that I think about when I think about SARS-CoV-2 and its long-term complications. One is the scale of it. Is the idea that there are literally billions with a B, billions of people in the world who got infected with SARS-CoV-2. So do we have post-Ebola syndrome? We do. But there are no billion people in the world with Ebola, right? Mm-hmm. Do we, so I think that one of the distinguishing characteristics is the scale of it. Two, to your point, and you're absolutely correct, is really also the scope of potentially the organ dysfunction. When I think about EBV, it's like, okay, well, EBV may lead to multiple sclerosis. That's well-defined illness. It's one thing. There are, sort of some ramifications in post-Ebola, but it's also contained in a few organ systems. I think the distinguishing characteristics of SARS-CoV-2 is it's really broad. It can nearly affect every organ system. So these are two, the scale and the scope are what sort of distinguishes SARS-CoV-2. But more broadly, it still should be, we should think about it as a post-viral illness. And I think deciphering the mechanism and understanding it and understanding how to treat the post-acute sequela of SARS-CoV-2 will not help us only address the problems of people with post-acute sequela of SARS-CoV-2, but will help us even understand how to treat the post-viral illness more broadly, and also help us in pandemic preparedness. Because one of the things that is almost certain, you can bank on it, all of us, is that pandemics are going to happen. We just don't know if the next pandemic is going to be in 5 years or 10 years or 100 years, but they're going to happen. And it's very, very important that we learn. We already paid a hefty price in this pandemic and millions of lives lost around the world. We already paid the price. Might as well learn from it as much as we can and develop the science. So when we get, when we have to face the next pandemic, we're better prepared. You asked a question about sort of like why SARS-CoV-2 is different than, say, the flu or Ebola or EBV, and why the sort of the scope of organ dysfunction is so broad. The short answer, we don't completely understand. I mean, short and honest answer, we don't really know. I mean, as I sort of relate back to the hypotheses that I've explained, and it could be, that the SARS-CoV-2 for some reason there is it has more predilection for viral persistence that may lead to downstream ramifications in several organ systems. It may be that the inflammatory effect that it provokes in the acute phase, sort of a stronger for properties related to spike protein, the ACE2 receptor, other considerations. There is, again, the microbiome hypothesis. So there are potentially ideas to explain this, but I have to say that we don't really fully understand why SARS-CoV-2 is so much different than say flu or Ebola in its ability to wreak havoc in so many organ systems.
Okay, before asking Luis to give another contribution, I'd like to introduce another dimension, that is time. How early can you detect an increased risk of any of the cardiovascular problems that you have characterized? And what about longer term follow-up of your cohort? It's now over 1 year since you published the Nature Medicine paper. So presumably you may have taken another look at the same database and what's happening.
Oh, absolutely. This is really wonderful. So first of all is like sort of the time horizon or risk horizon. So we see increased risk of heart problems in the acute phase. Obviously people in the acute phase can get heart disease and heart attacks and et cetera, et cetera. And in the post-acute phase, beyond the first 30 days, beyond the 90 days. And the risk, at least in our published work, seems to persist up to a year after the infection. So that's really the first component of your question. We're very, very, very interested in sort of thinking deeply and doing work characterizing the trajectory of illness going forward after the first year. Mm-hmm. And we have work under, Charlie and my team and others are doing some work now to characterize 2-year outcomes for a variety of organ systems, including cardiovascular disease. Tracking these patients for 2 years, and ultimately we also want to, we have a sort of grant from the VA to work on 3 years, and those are very, very, very important to your point, because we want to understand how does the risk sort of behave over time. Does it sunset? At what point in time the risk is risk from the infection is really neutral? What complicates these analyses is that obviously now a lot of people are on their second infection and third infection, so it's like very hard to find someone who has only one infection, and there is also the potentially mitigating effects of vaccines and antivirals, and then the idea that the viruses have changed over time. The SARS-CoV-2 itself has dynamically changed over time, so the risk profile of Omicron per se is different than Delta, is different than ancestral strain. So we're thinking deeply about those things, and my team and I are certainly have work we're working on the 2-year, and we have also on in the horizon working on 3-year outcomes of SARS-CoV-2.
Thank you, Luis.
I was actually wondering whether there was Ziyad, in your paper, any survival analysis or graph, over this 1-year period, which I understand that's the maximum time period considered in your study, but I don't think I found it. But you just said that the risk was, if I interpret correctly, that the disease excess risk was constant starting from day 31 until day 365. Do you have some data to show that? That would be quite helpful.
I wouldn't say constant. It's not, but the risk persists up to a year. And in that paper, because there's so many outcomes, we didn't there was no or survival curves, but we have work that hopefully should be coming out on 2-year outcomes, and those will have the full sort of survival curve for 2 years.
And do you have any idea how this will look like, or not yet?
I'm not at liberty to discuss, so I think the 2-year outcome we have to.
Okay.
I'm not at liberty to discuss, but the 1-year outcome is in the public sphere, and I can tell you that the risk is persists after a year. I wouldn't say it's constant over time. It's not constant over time, but it's certainly evident at 1 year.
Okay, so maybe there's a small decline, you mean, over time, no? That's what you mean, no? A small decline.
Yes.
Okay. The thing with what I mentioned, with the comparability in first the patients themselves who have the disease and who don't have the COVID, and also the difference in healthcare provision, to people with COVID and people not with COVID. When you're going to do now this comparison over 3 years, there's one additional thing I don't know if you have considered, that not only most likely it's slightly different, as I said, the healthcare provision and surveillance of people with COVID-19 infection and people not. I mean, surely there is a difference, but also that people with COVID-19 over this now 3 years period will also have a change in their healthcare monitoring. Most likely, people will be more likely to be more acutely followed, during the first months, a year, and most likely that also will decline. How I know it's close to impossible to adjust for that, in observational data, but have you considered that? So in other words, the absolute incidence, if we just measure the disease, not in relative terms, but in absolute, most likely will just decline over time, after the first year, for 2 reasons. One, because maybe it just declines because there is a mechanism that there is short-living, and then after 1 year it declines. And the other is that the change in the surveillance, over time, people just get tired, of being so active, looking for assistance, both in the system, both coming from the system and coming from the patient. I don't know if you will be able to address that in one way or the other.
Okay. So this is a very interesting idea. So we're certainly very interested in thinking deeply about healthcare utilization and the trajectory of healthcare utilization over time. And it's very, very clear to me that this is really a dynamic parameter. And actually, certainly a lot has changed over the past 3 years from health systems that were nearly massively disrupted in 2020, where healthcare capacity was constrained for a variety of reasons, and things have evolved and changed in 2022, 2021, and 2022, and then 2023. So there is a lot of dynamic changes at play, and we're certainly cognizant of the fact that these could play a significant role in burden estimates.
Okay, let's go back to the audience. There is a question from Valentina Puntman among all the others that I think is fits very well on this topic, because she's asking, are we emphasizing the increased need for cardiovascular risk management and prevention strong enough? Who do you think should really be leading on this? Cardiologists, general practitioners, post-COVID clinics? So briefly, otherwise there is no room for the questions from the audience that are really a lot, very interesting, all of them.
So the brief answer is all hands on deck situation, all of the above. And I think there is no way that only specialists can deal with all of this. There's no way. We have to figure out a way of empowering the primary care providers to be able to do most of the work. That's really the foundation of our medical system in the US and elsewhere in the world. And then subsequently refer complex cases to specialists. And I think that's really going to be the key of dealing with that huge demand.
Okay, perfect. Then there is Mrs. Perk telling us that remembering us that we have a lot of to learn from individual cases still, like individual case reports when it comes to a newly discovered cardiotropic virus. And maybe here I would like just to add a little bit of comment. Virus infections are, the type of environmental hit that maybe can even change your having an impact on epigenetics in general. So maybe we see something now, but we will see even some more and different maybe later on. What do you think?
Oh, definitely I agree. And I think one of the experiences in this pandemic has sort of humbled us and sort of really shed some light on the connection between viral infections and non-communicable diseases, including heart disease. And I think this happened also during the course of the pandemic. We learned that EBV causes multiple sclerosis like years down the road, 10 years down the road. So I think we have to be open to the idea that SARS, like we're not done with SARS-CoV-2, and there may be latent manifestations that may manifest 5 years, 10 years down the road. And I definitely agree with you also on the epigenetic changes. We're on the same page.
Okay, then Cesare De Gregorio is asking you about a patient who survived cerebral vein thrombosis after COVID disease or vaccination. Do you have a high risk score for future systemic thrombosis? You have this data about this type of patients?
So we don't have sort of systematic analysis or a really empiric data to inform the answer to this question. Generally speaking, if somebody had developed like a thrombotic event once, they're at a higher risk than the rest of the general population of developing the thrombotic event again. So that's sort of generally. I don't have specific data to address this question.
Okay, then there is from Miayokai a question that you have already answered about what is going to happen after 1 year, but you already answered these questions that was asked from Professor Patrono earlier. And okay, what about Carlo? You have other questions from your side, or go ahead with the audience?
Well, just one question. You have also published an interesting paper in The Lancet about diabetes and the fact that you find a 40% increase roughly in diabetes risk. Would you like to comment briefly? And then we give the word to Filippo, who raised his hand.
Sure. So I mean that paper now is also like maybe like a little bit more than a year old, and we've done the work to sort of characterize the relationship between SARS-CoV-2 infection and long-term risk of diabetes. This is diabetes at 1 year. It's clearly a signal. I was very iffy when we first got the data. I was like, how can this be? I was skeptical. I basically told my team, this is wrong. It cannot be true. I don't see how can SARS-CoV-2 lead to higher risk of diabetes. I just didn't see it. I was very
particularly
skeptical.
within a short time.
I was very doubtful that this is really true. You know, we read it the analyses. We changed the analyses, that was true, and ended up publishing it. And now there are 20 papers from throughout the world saying pretty much the same thing. There is increased risk of diabetes. So it's very, very clearly that something about SARS-CoV-2 sort of results in increased risk of diabetes. And some people sort of, it may expedite the development of diabetes that we're going to have anyway, but years down the road, so it may accelerate the development of disease. And then in some individuals, it may produce de novo disease. So we're still trying to sort of think deeply about what the mechanism, how is this really happening in people? But it's good to see, not good for patients, but from a scientific perspective, good to see the evidence reproduced 20 times in multiple different settings throughout the world.
And do you know whether this is primarily insulin-dependent diabetes or insulin-independent?
Type 2. The lion's share is type 2, and even in the CDC study where they did it in younger adults, in which case in younger adults generally they get more type 1. They actually had more type 2 following SARS-CoV-2 infection. It doesn't mean type 1 cannot happen, but really the majority of the lion's share is type 2.
Filippo, you had a question?
Yeah, a question related to what Ziyad, you said before. What makes COVID so special compared to other viruses? What about ACE2, which mediates the infection and is so important for cardiovascular homeostasis? Do you think that this might be one of the reasons explaining this observation?
I mean, as you know, there is lots of different opinions about this, and there is a lot of different papers about this. But it certainly has been proposed as a potential mechanism to explain why, as you all know, the ACE2 receptor is nearly ubiquitously present on multiple cell types, right? So it's in multiple cell types in the human body. And the idea that sort of the spike protein on the surface of SARS-CoV-2 can interact with the ACE2 receptor and then subsequently alter downstream signaling and so that's a potential mechanism. I'd like to see more empiric data supporting the idea that this is really the key mediator of organ injury. I still don't think we have firm data there yet, but it's certainly a plausible why with SARS-CoV-2 of all the viruses have this sort of this really very wide array of organ dysfunction associated with it. It could be an explanation that the spike protein interaction with the ACE2 receptor. But I think we need to be as scientists skeptical until we see more empiric data supporting this idea of thinking, see that this really actually is what explains the downstream organ dysfunction or organ injury.
Great. There is a very short question about is there any histologic evidence of viral persistence in the endothelium, and I will add in the myocardium or in other type of tissue that is relevant for cardiovascular diseases?
Yes, so there is. I mean,
we are approaching the end of the dialogue, Ziyad. So very short answers, so we can.
Very short
ask
answer.
To you more.
The best paper on this is a paper by Dan Chertow from NIH and published in Nature about 6 months ago, in which they did autopsy studies on people many months after SARS-CoV-2 infection. They were able to culture the virus from the brain tissue, from a variety of organs. The paper is in Nature. The first author is Dan Chertow from NIH. Beautiful work by Dan and his team, and 44 cadaver, cadaver. They were able to. It's really brilliant work. They were able to culture the live virus from several organ systems many months after the initial infection.
Perfect. And then there is Geoff Hackett that would like to tell us that speaking as a survivor of 3 months ventilation in intensive care unit with complicated meningitis, encephalitis, and a 1-inch clot in the hippocampus, it is impossible to link all long COVID cases together. By the way, in answer to my earlier questions, was the questions about the testosterone topic with diabetes. My total testosterone was 2 nanomol, and treatment of this has led to complete recovery and my return to work. So I'm very happy. And it's like I would like just to finish his comment, because I think we should be very happy for his successful, recovery. Then we would like all together to welcome Prof. Brownwald in the audience. This is really a great honor. I agree. Please, you were saying something.
I was gonna go ahead, please. Go ahead.
Again, there is another question about the type 2 diabetes that you have already answered. So I think we have more or less done with all the messages. Okay, again, there is a question about the vaccines, and you have already answered this question. So I think we have done with the audience questions. And what about, okay, Professor Crea has another question.
Well, I'd like to come back to what you said before. In our audience today, we have Professor Brownwald. And Ziyad, you probably know that we cardiologists, we disagree on many things, stent versus surgery and whatever. But we all agree that Professor Brownwald is the most important cardiologist in the world, and is really the father of all cardiologists in the world. So I'm really very happy that he's with us. And Jean, if you have questions, please.
Well, I learned a great deal from this conference, and I have just 2 questions. You alluded to the fact that the virus has changed. Now, has that influenced long COVID? Because we've gone through 3 or 4 variations of the virus. That's question number 1. And question number 2, in patients with established cardiac disease, has long COVID resulted in any deaths? Because we hear a great deal, and in our hospital we saw a number of patients who are immobilized. And you've gone through that extremely well. But have there been fatalities because of in underlying cardiac disease?
Well, thank you for the question. It's really also, and you know, your name is I'm a nephrologist by training, so I'm not a cardiologist, but it's certainly, you have this broad recognition. So thank you again for being you and all your contributions to medicine in the US and worldwide. So really an honor to also, you know, have a question from you. So first, sort of as to, you know, the virus certainly evolved. There's an ancestral strain, you know, subsequently we had Delta and Omicron, and even Omicron itself spawned so many subvariants. You know, there's BA1, BA2, BA4, BA5, XBB 1.5, BQ111, you know, you name it, there's tons of variants. So when we track, you know, long COVID after these different, sort of COVID or the different variants of COVID, it's very, very clearly it has mellowed down over the years. It's very, very clearly that the ancestral strain was really the most aggressive and associated with a higher risk of long COVID, you know, and subsequently Delta and Omicron now, and all its descendants or its subvariants associated with less long COVID. So that's not to say that long COVID is gone. You know, the virus still is circulating, it's still mutating. We don't really know what the future variants will hold. But as it stands today, Omicron and its descendants or its subvariants seem to be associated with less burden, less risk, and less burden of long COVID. The second question in the people who had long COVID or the people who had established cardiovascular disease and subsequently got long COVID, are there any fatalities? I mean, the short answer is yes. We clearly see increased risk of death in the post-acute phase of SARS-CoV-2 infection, and that actually persists up to several months after the acute infection. A lot of people sort of think that once you survive the first 30 days, you're out of the woods, but a lot of people get clotting, get heart problems, strokes, and then they succumb to it many months after the acute infection. So certainly there are fatalities, increased risk of death months after the acute infection. That's been reported in some of our studies and multiple other studies from the US, the UK, Germany, and many other places in the world.
Well, thank you very much. You answered both questions very clearly. Thank you.
Perfect. Thank you very much. If there are other questions, please, because we have, passed the hour. So it was really a great topic with a lot of questions. The last questions, if you would like to ask the last one.
Giovanna, can I come back? Thank you, Ziyad, for this wonderful hour. We are relaxed. Doesn't matter if it is a bit longer, a bit more than 1 hour. What is important is to have an enjoyable and useful conversation as it has been today. So I take this opportunity first to thank Carlo and Giovanna and Massimo for organizing this brilliant dialogue. The first dialogue was, Ziyad, was with Professor Brownwald on the 400 years of cardiology. That was the beginning, was really wonderful dialogue. By the way, you can go back to this dialogue if you go to our website. All dialogues are there. They can be found in YouTube and now also in our Twitter account. But the first successful dialogue was with Professor Brownwald, and today has been another wonderful dialogue. I have the last question. You are not only a great scientist, but also a brilliant speaker. So I ask you a difficult question. Can you summarize the important take-home message you have given today? You have a massive experience in this field. So in 3 pills, what are the take-home message for our audience to remember from today?
That long after the public health emergency or after the COVID-19 pandemic recedes from public view, and for a lot of us, it's actually in the rear view mirror. We're going to be dealing as physicians, as public health practitioners, as scientists with the lasting legacy of SARS-CoV-2 infection. So SARS-CoV-2 infection can produce acute problems in the first 2, 3, 4 weeks, but it can also produce long-term effects that for some people will last a lifetime. And I think if you remember one thing from this talk is that the pandemic will be gone at some point in time in different countries and will be in our rear view mirror. I will recede from public view. But what will last with us for many generations is really its lasting effect on those long-term effects on organ function. People who have diabetes likely have diabetes for a very, very long time, for maybe for a lifetime. People have heart failure. They don't wake up tomorrow and say, hey, gee, I don't have heart failure anymore. That's really a chronic condition. Is it manageable? Absolutely, yes. But is it curable? Not necessarily so. I think this is really one of the things that people need to think about, that there are long-term consequences of SARS-CoV-2. And maybe number 2 is that the idea that viruses produce long-term manifestations. SARS-CoV-2 is unique and it's not. So I think we need to be vigilant and think about really this broader link between viral infections or infections in general and non-communicable disease. And I think that's very, very, very important to really help us improve the health conditions of our populations going forward, paying attention to those proximal risk factors, among which there are going to be infections. And 3 is really like we paid a hefty price in this pandemic in losing millions of lives. So might as well honor those lives by learning as much as we can from this pandemic to face the next one and do a better job. I think, in my view, we didn't do so well in this pandemic, and I think it behooves us. We already paid the heavy price in terms of millions of lives, more than 1 million people in the US, and many, many, many more around the world. These people lost their lives, and some of them could have been prevented. I think we need to learn to do better the next time around.
If I can, just 3 questions with 3 answers, very short. Could long COVID be prevented? More or less, you have already answered, but very, sharp. Could
yes, to some extent, vaccines reduce the risk, and also antivirals. And I think we need to trial other therapeutics to figure out how to maximally prevent the development of long COVID. So
this is a key message. Other question for a key message. Could targeted early diagnostic strategies for long COVID be developed? So something that in the huge amount of people who is infected, if I can early identify the ones that will develop long COVID?
So this is a very brilliant question. There's no short answer there. There's a lot of research being done on figuring out biomarkers for long COVID and trying to, do early diagnostics and all of that. That's being worked on by a lot of labs in the US and in Europe. So the answer to that will have to come in results from those research labs in the next several months.
The last one, should treatment be different if I get acute coronary syndromes because of a long COVID consequences, or if I get heart failure? The treatment should be the same or should change? I have in mind one particular case.
This is brilliant. The current thinking is that it should be the same, but I think we really don't know the answer to that. I mean, to be honest, we don't really know the answer to this question. I think we need to, delve deeper and try to understand it better. Currently, what we do, I have to tell you, it's pretty much the same. But I think the true answer is that we don't really know.
Okay, Carlo.
Before giving a final word to Luis, also, I'd like to ask you, Ziyad, do you think if we take a public health perspective and realize that cardiovascular disease, the existence of cardiovascular disease, increases the risk of severe COVID, and on the other hand, severe COVID impacts on the cardiovascular system, that in looking ahead at the next pandemic, the best way to be prepared would be to improve cardiovascular health of the population?
Undeniably true. And I think one of the things that sort of made sort of the general, the high risk of problems here in the US is that we entered this pandemic as a sick nation. We have a higher BMI than we should. We have a higher smoking rates than we should. We have, not as many of us really exercise. We have a high burden of cardiovascular disease, even entering the pandemic. And exiting the pandemic, the rates are going to be higher. And I think it behooves us to optimize, because pandemics are going to happen. Challenges like that are going to happen. To definitely be better positioned to face the next pandemic, healthier nation, healthier population with lower risk of or lower burden of obesity, lower burden of risk factors like smoking, hypertension, lower burden of cardiovascular disease, will certainly be able to be more positioned to deal with it or to navigate it more gracefully.
Luis, a final word of wisdom?
Well, wisdom, I don't know. But just looking at the data clearly, as I said before, I mean, it's close to not possible to predict who's going to have this excess burden, who with a name and a last name, no? But what you can do is, once again, target population. That's what we always do in public health. And once again, coming back to the data of this paper, you go to figure 5, and you see that the excess burden for 85% of the people who had COVID was no more than 1, 2, or 3 per 1,000, basically person years, because the period that Dr. Aly examined is that. So these people have a very small excess risk. So these are not the people you should be caring too much. And if you go to the people who were hospitalized, survived there, we're not talking about 1 or 2 or 3 per 1,000. We're talking 30, 20, 50. That's a different ballpark, no? And so that's where I think you should concentrate your efforts, no? So in the people who have had this serious COVID, most likely will also have a greater likelihood of having a long-term consequence as this cardiovascular. The people who have a relatively mild COVID, so outpatient COVID, well, it's barely noticeable, 1, 2 per 1,000. I don't want to understate that, but it's really small. I mean, it's really small. That's my reading of the data in an optimistic way.
So this is the point of view of an epidemiologist, an outstanding epidemiologist. As cardiologists, we should take care also of the single patient. Anyhow, it was really a good dialogue, I think. I really would like to thank Dr. Ziyad Al-Aly. He is really a brilliant scientist, but also a brilliant speaker. I would like to thank our discussant, Dr. Garcia Rodriguez, that is an important and eminent epidemiologist, and put all the things that as scientists we said, put more on the flow, so they are more now available to be used also by clinicians. And I would like to thank my colleague of the weekly J-Scan section of the European Heart Journal, of course, our editor-in-chief, and I'm so honored to have Professor Brownwald with us, and also to have a question from him. That really this was a very good afternoon. Thanks to all of you, especially to the audience, of course.
And do not forget that the next dialogue will be on May 25 at 17 Central European Time, as usual, last Thursday of the month. Thank you again, and please come back.
Thank
you.
you.
Thank you for having me.
Thank you.
Bye now.
Thank you, Ziyad. Thank you, Luis.
Thank you.
Thank you. Bye.